مرحبا جميعا، يعطيكم العافية. اسمي حنان عليان، أنا أخصائية تقويم أسنان وفكين. عم بتكلم معكم من عمان الأردن. لكن إحنا قلوبنا وعقولنا وإيدينا كلها منهمكة معاكم طبعا. شعبنا الغالي جدا من قطاع غزة. نتمنى لكم القوة والصلابة، وإحنا فخورين فيكم، وإن شاء الله إنه الأيام هاي رح تتبدل ورح تفرج عليكم. وغزة معروفة إنها دائما أعلى نسبة علم وتعليم في العالم العربي، فإحنا كتير فخورين فيكم إنكم مستمرين رغم هذه الظروف الصعبة، إنكم تحضروا المحاضرات بأي طريقة متاحة لكم. إن شاء الله إنه تستفيدوا وتكون سهلة عليكم الأسلوب هذا التعليمي الجديد أونلاين. إذا عندكم أي أسئلة بتمنى تتواصلوا معي، رح أحط لكم إيميلي في النهاية. وإن شاء الله خلينا نبدأ في أول محاضرة للتقويم لسنة رابعة، وهي ال Introduction to Orthodontics. العناوين اللي راح نتطرق لها بهاي المحاضرة هي تعريف إيش يعني Orthodontics and Dentofacial Orthopedics. رح نحكي شوي عن تاريخ الديسبلين. رح نحكي كيف ال goals of treatment changed over the years. شو يعني mal-occlusion أو سوء إطباق، شو ال prevalence تبع سوء الإطباق، وشو الراشونال أو المبررات خلف العلاج التقويمي. So orthodontics, simply put, ortho means straight and dontics means teeth. So orthodontics just means straight teeth. So orthodontics is the field that is concerned with straightening teeth, aligning teeth. It's a specialized field of dentistry. It's how is it concerned with straight teeth? It needs to identify, diagnose, it needs to correct, and sometimes it needs to intercept، يعني تتدخل. إذا هي بتشخص، بتعالج، وأحيانا تتدخل في المشكلة قبل نشوبها، نخففها أو نمنع حصولها. أوكي. مال occlusion اللي هو سوء الإطباق، اللي هو simply put misalignment أو عدم وجود اصطفاف، أو خلينا نحكي تناسق بين الأسنان بالفك الواحد أو بين الفكين مع بعض. هلا زمان كانوا يحكوا orthodontics purely، بعدين صاروا يحكوا orthodontics and dentofacial orthopedics. dento يعني بنعرف أسنان and facial هو وجهي، يعني صرنا نحكي تقويم الأسنان والفكين. orthopedics اللي هي زي ما نحكي جراحة العظام أو علاج العظام. هل يستطيع أخصائي التقويم التأثير على عظام الفكين؟ نعم، رح ناخد هذا بالمحاضرات القادمة لما نحكي عن growth modification, how we can modify growth, or how we can have a part in orthognathic surgery اللي هي الجراحة التقويمية. So it's not just about the teeth, it's also about the jaws and their presence and alignment and appearance within the face and function, of course. Orthodontics is not new. There has been historical evidence when very old artifacts suggesting that people were always concerned about their teeth, if they were protruding, يعني coming out, بارزين, malaligned, okay? And there has been evidence that doctors or dentists have attempted to straighten teeth in the past من يعني 2000 قبل الميلاد. So when it first started, it was mainly concerned with just aligning teeth. Slowly things developed. They started to care about occlusion, mainly because of the need of prosthetics. So dentists started to understand that there needs to be a bite, a functional bite. We need to have the teeth in certain positions, not just to have them aligned regardless of how they are aligned. So they started to understand that there needs to be good occlusion. And then people started to take note of their aesthetics, and so they started to demand teeth that are not just aligned but are more aesthetically pleasing within their face. So aesthetics came into play. And then cephalometry, which was discovered after World War II, made us understand a lot about the relationship of the teeth within the bone of each jaw, and the relation of each jaw to the other, يعني the maxilla and the mandible to each other, and each of them to the base of the skull. And this development, especially the cephalometrics, led to a huge development in orthodontics in terms of how can we align teeth, what is the scope، أو قديه بنقدر نقدم الأسنان لقدام ولورا within the alveolar bone، قديش ال bases of the skull المجزلة والماندبل بعاد أو قراب عن بعض، وقديش هم بيأثروا على شكل الوجه الخارجي وعلاقتهم within the base of the skull قديه بتأثر على طول الوجه أو ال concavity أو ال convexity of the profile. So as our understanding advanced, orthodontics as a field advanced extensively. يعني it's not just about aligning teeth now. When the orthodontist wants to align teeth, they have to take care about the alignment looking better in the face now and making the face look better, making the smile look better, and also making sure that after they align the teeth, they have provided the patient with good occlusion, with a healthy occlusion that is functional. So the treatment objectives now are not just aligning teeth, they are more comprehensive. They have a wider outlook on the patient's dental health and aesthetics. And of course, just like how dentistry evolved recently, orthodontics also evolved extensively. يعني إحنا بنحكي عن treatment approaches and modalities within the last 20 years that are hugely different than what we used to do before. We are now moving teeth with plastic, not just with metal braces, which is like clear aligners. Clear aligners are made of plastic. There are now anchorage devices called temporary anchorage devices, which are small mini screws or mini implants inserted in the bone that can help us move teeth in directions that we were not capable of doing before. We are talking about incorporating digital smile design so that we can give the patients the best smile that fits their face. We are talking about multidisciplinary approach where the orthodontist helps the prosthodontist and so on. Okay, so when we talk about malocclusion أو سوء الإطباق إيش يعني؟ It refers to the misalignment or incorrect relation between the teeth of the upper and lower dental arches when they come into contact. It can manifest as an improper positioning of individual teeth within each jaw, okay, or the misalignment of the jaws to each other, okay. طيب, so malocclusion is not itself a disease. يعني سوء الإطباق هو مش مرض, هو بس simply put a deviation from ideal بين قوسين ideal or normal occlusion. وهلأ رح نحكي شو معايير إن إحنا نحكي عن occlusion إنه it is ideal or normal و what is the deviation from it, ورح نعرف قديش هذا المعيار هو عالي جدا حتى إحنا نقرر إنه أي حدا ما عنده هذا ال ideal occlusion هو needs treatment, okay? So if we want to talk about ideal occlusion, we want to talk about scientists that studied occlusion in the population and then came up with several classifications and key features of what's an ideal or a good occlusion is. اوكي سو درسوا الأسنان والإطباق وقرروا إنه يحطوا مجموعة من الفيتشرز والكلاسيفيكيشن اللي بتحكي إنه هذا هو good occlusion وأي إشي مش ما عنده هاي الفيتشرز هو deviation or a malocclusion. من أهم الأسماء بهذا النطاق هم إدوارد أنجل ولورنس أندروز. Edward Engel was actually a prosthodontist, so he cared a lot about occlusion. وبالنسبة له he قرر إنه the classification depends on the occlusion of the first permanent molars of the upper, how they occlude with the first permanent molars in the lower arch. Okay, he also cared about good cuspal interdigitation to provide mutual support for teeth in function. بيجي بعده ب100 سنة Lawrence Andrews, and he studies the population and comes up with certain features for how the occlusion should look like when in static occlusion. Okay, so this is Edward Angel, who in the 1800s classified the teeth according to the relationship of the upper six to the lower six, زي ما حكينا. Okay, so it was a relationship that is based on the anterior-posterior relation of these two molars together. And he said that the mesiobuccal cusp of the upper first molar should occlude in the mesiobuccal groove of the lower first molar, and this constitutes a class 1. Okay, so again, it is the anterior-posterior relationship of the upper first molar to the lower first molar. Okay, so a class 1 malocclusion is according to Angle, has a normal molar relationship. يعني الميزوبكال cusp is occluding with the mesobuccal groove of the lower. Okay, بس في عنا other problems like misaligned teeth, rotations, crowding, spacing, whatever anterior to it. Okay, and then there is class 2 and class 3. Class 2 is where the lower molar buccal groove is positioned distally or more posterior to the cusp. دايما اعرفوا إنه بالتقويم we talk about the relationship of the lower arch to the upper arch. Okay, so class 2 is when the lower arch is behind the upper arch. It is occluding distally or posteriorly. Class 3 is the opposite. It's when the lower arch is occluding more anteriorly or more mesially to where it is supposed to be. So class 3 is where the lower groove is more anterior or mesial to the mesiobuccal cusp. Okay. طبعا Angle's classification has a lot of drawbacks لأنه he assumed إنه a class 1 molar occlusion means that the patient has a class 1 skeletal relationship. يعني the relationship between the maxilla and the mandible is skeletal class 1. And we will talk about that later in the lectures of diagnosis and classification of malocclusion. Okay, and the class 2 that means that the mandible is behind the maxilla, and the class 3 means that the mandible is anterior to the maxilla. بس بالحقيقة لا، لأنه هذا معناه إنه ال first molar position is stable, which is not، لأنه ممكن تتغير علاقة ال first molars مع بعض مش بس حسب إيش علاقة الفكين مع بعض، بس برضه ممكن يصير في عنا developmental issues like early loss of primary molars and that can change the relationship. بس هو مبدئيا Angle كان بيشوف إنه molar relationship it establishes or it is a description of the skeletal relationship. برضو another drawback إنه هو بس كان عم بيطلع على anterior posterior relationship of the molars، ما كان عم بيحكي عن ال transverse اللي هي ال crossbites، وبرضو هاي رح نحكي عنها بالمحاضرات الجاي. طيب what about Andrews؟ Andrews إجا بسنة 72 and he analyzed 120 بين قوسين normal occlusions. Okay, I can attach the paper تاعت Andrews so that you can all read it. Okay, he actually analyzed 120 stone models of teeth that he collected from different offices and universities, and his personal opinion was that these look like normal, good occlusions that will not benefit from orthodontic treatment. And then these 120 models, he compared them all, and then he saw what are the key features that are repeating in all these cases. And then after he studied them, he came up with these 6 features that he decided are the 6 features that can constitute a normal occlusion if they are all present together. Okay? بدنا نعرف إنه Andrew's keys of normal occlusion, they are not a method of classifying, يعني they are not a classification system, not like angles. However, they serve as a goal. يعني هم زي قطعة البازل، بحكي لك إنه إذا الستة موجودين مع بعض رح أوصل ل good class 1 normal ideal occlusion. إذا في واحدة منهم missing, I cannot attain a class 1 occlusion. Sometimes we as orthodontists, when we are working on a case and aligning a patient's teeth, إذا ضل عنا error بالنهاية sometimes and we don't know what it is, we look back at these 6 keys and then one of them would be off, and then if we correct it we can attain the class 1. Okay, and also you have to know that Andrews used this analysis to develop the first pre-adjusted أو اللي بنسميه زي كأنه pre-programmed bracket system. يعني البراكتس هم فيهم programming معين how to align the teeth, okay, in 3 dimensions. We will talk more in the next slide. So the first key was like Angle. He talked about molar relationship, of course, the upper molar with the lower molar. Okay, but he added one important thing because he noted that sometimes the upper molar is smaller in size than the lower molar. So it's not just about having the mesiobuccal cusp in the mesiobuccal groove, but also he talks about having the distal incline of the distal marginal ridge of the upper first molar occluding with the mesial incline of the mesial marginal ridge of the lower second molar. يعني إذا السكس صغير بالحجم وكانت الميزوبكال كسب داخلة هون ممكن ما تكون الديستوبكال كسب داخلة بهذا الامبريشر. بالنسبة لأندروز لا، هو بده يشوف كسب تفصة، بده يشوف كمان إنه هاي الكسب الديستال كسب هي فايتة بالامبريجر between the 6 and the 7. Okay, let's talk about key number 2 and key number 3. في هون مهم إنه نعرف نفرق بين كلمتين angulation اللي هي نفسها التب and inclination أوكي اللي هو نفسه التورك. angulation اللي هي لما أطلع على الأسنان من قدام أشوف الميزو ديستال تب تبعهم. What does it mean؟ يعني بيجي بيحكي لك أندروز إنه كل ال crowns كل ال teeth actually inside the mouth I have to see that the crown is slightly mesial to the root. Okay, so the crown is mesial and the root is distal. The central, the lateral, the canine, all of the teeth in the mouth, they have to have a mesial angulation or a mesiodistal tip. Okay? While the inclination is لما أطلع على الأسنان من جنب in a buccolingual direction. And Andrew says that for incisors upper and lower, the crown has to be more labial and buccal than the root. Okay, this is the normal key or normal feature. بينما for all the buccal teeth, starting from the canine and going backwards to the molars, in the upper and in the lower بالعكس, the crown has to be lingual and the root has to be buccal. يعني زي هيك بيكون بدل ما يكون زي هيك. Okay, and this torque, the خلينا نحكي lingual crown torque in the lower is progressive. يعني بالفك السفلي كل ما نرجع لورا كل ما نلاقي الأسنان بتميل لجوا أكتر. Key number 4 says no rotations. يعني لما لو أطلع على الفك من occlusal aspect I don't see any rotation. I don't see any spacing. We have tight contact between all the teeth. Okay. And the last key, which is a flat occlusal plane. يعني occlusal plane is the plane that connects the incisal edges with the buccal cusps of the posterior teeth. It needs to be on one level. لما نطلع مثلا على هاي الصورة when the incisors are more upwards than the molars and the premolars بيكون في عنا curved spine. I think إنكم أخدتوا هذا الحكي بالocclusion. So Andrew's last key says that there has to be a leveled occlusal plane. يعني all of the teeth has to be more or less on the same level. Now you have to know that orthodontists traditionally base their treatment plan upon the aforementioned static goals and others that we're going to discuss in the next lectures. So we talk about static occlusion. We don't plan our treatment according to how the dynamic occlusion is, okay? But it is important for you to understand some concepts about dynamic occlusion, and then we will talk towards the end of the lecture why we don't always stress on reaching the dynamic occlusion that is mentioned here, okay? So a lot of textbooks and scientists describe the ideal functional occlusion in a mutually protected occlusion اللي هو ال anterior teeth protect the posterior teeth during protrusive and lateral movements and the posterior teeth protect the anterior teeth during centric occlusion. Okay, you can read about it. We know that probably أخدتوه بالocclusion أخدتوه بالprosthodontics that the mandible is the moving jaw, the maxilla is the jaw that is fixed to the base of the skull. The mandible is the jaw that moves. So when we are doing protrusive movements, we need the incisors anteriorly to guide the mandible or the incisors to slide past each other بينما بيكون عنا immediate and permanent disocclusion posteriorly ورا بين الطواحين والbuccal teeth. Okay? بينما when we have lateral excursions or lateral movements, we need to have the canines do that job for us on the working side and have a total disocclusion on non-working side. We either have a canine guidance or a group function guidance. Okay. بينما على intercuspal position we need to have multiple bilateral contacts of the posterior teeth and slight disocclusion anteriorly. So to get real, in reality, an ideal static or functional occlusion actually is rarely found in societies. Okay, there is a high occurrence of traits of malocclusion. لأنه حكينا malocclusion is any deviation from the ideal occlusion. So actually malocclusion is the norm. طيب نحكي عن prevalence of malocclusion. Most studies that studied malocclusion among different populations reached numbers as high as 95%, where only maybe 5% have normal occlusions, according to this classification. فهاي it really underscores the need for a clear definition of what constitutes normal. يعني مش أي إشي that deviated from normal that means إنه we have to treat it. Okay? It has to affect function, it has to affect aesthetics, the patient needs to seek treatment, there needs to be an advantage of the treatment that clearly outweighs any disadvantage from the treatment. And of course, malocclusion can affect all ages, بس أكتر إشي it is studied amongst children and adolescents, as this is when orthodontic issues are most easily corrected. Nowadays, we are seeing as the discipline of orthodontics يعني advances, we are seeing more and more adult patients who were not able to get treatment when they were young. They are more and more seeking it now as adults. طبعا it is important to know that the differences in malocclusion prevalence are noted among racial and ethnic groups. يعني genetics plays a big role in the types of malocclusion. And there are developmental issues, there are environmental issues. So there are things that are actually considered normal in some ethnicities and races and not normal in others. يعني بنلاقي Southeast Asians they have a lot of prominency in their teeth يعني proclined upper and lower incisors اللي هم بارزين لقدام is a lot more common, which is يعني considered normal in them compared to Caucasian populations. We will talk about that later on. In the next lecture, I will also talk about the prevalence of malocclusion in Palestine. We will discuss some certain classifications of malocclusion and discuss their prevalence in Palestine. Okay? Okay, so now we will be discussing some benefits of orthodontic treatment and the rationale behind the orthodontic treatment. بس مهم نعرف إنه orthodontic treatment is an elective intervention. elective يعني اختياري، المريض هو بيختار إنه يروح يعمل تقويم أو يكمل حياته كلها بدون ما يعمل تقويم. فأي علاج اختياري elective there has to be a clear benefit to the patient and it should really outweigh any potential risks. Okay? It is clear that orthodontic treatment أهم واحدة من البنفيتس هي cosmetic advantage to the patient. We know that most of the patients that seek orthodontic treatment, they can eat well, they can talk well, but they are not happy about the aesthetics of their smile. So this is why they seek orthodontic treatment. Let's talk about that more in evidence, okay? It has been proved difficult by evidence to provide strong evidence in support of the widely assumed belief that treatment can also improve oral health and psychological well-being in an individual. Okay, the next slides are going to talk about that in details. Okay, so let's talk about resistance to caries and periodontal disease. Can I rationalize my treatment as an orthodontist that I want to provide orthodontic treatment for a patient to reduce their caries risk or enhance their periodontal health or reduce the risk of developing periodontal health problems? Well, according to certain studies, orthodontic treatment may help reduce plaque levels by making teeth easier to clean. However, وخطين تحت كلمة however, they did not know whether that was because the teeth were aligned and this way made it easier for the patient to clean them, or because the patient was getting an active treatment and he was seeing an orthodontist regularly and this orthodontist was giving them instructions on oral hygiene and the patient's attitude toward their dental health changed. So this is why they improved their cleaning. Okay. We know that caries is endemic in a lot of societies, and it has to do with the presence or absence of the carcinogenic flora in the dental plaque and the intake of sugars and the type of saliva the patient has. So really it's يعني إذا بدنا نحكي according to evidence, there is very weak evidence to link orthodontic alignment of teeth and caries risk. This is number one. What about periodontal health? There is also weak evidence to suggest that orthodontic treatment will improve periodontal health. However, there is some relationships in some malocclusions, okay, زي anterior crossbites, we're going to discuss these in later lectures, and traumatic deep overbites. These two scenarios, if they are treated with orthodontics, then actually it can prevent periodontal breakdown in these cases. Okay, what about improved masticatory efficiency? Can I rationalize my orthodontic treatment by telling the patient, if you get orthodontics, you will chew better, you will eat better? Okay, according to evidence, again, there is a weak link between improved occlusion or treated malocclusions and masticatory efficiency. There are some studies that show that reduced occlusal contacts do appear to affect the efficiency of chewing, and other studies that show that the correction of class 2 and class 3 malocclusions by surgery, okay, high surgery يعني احنا بنحكي عن major change of the relation of the two jaws together, okay, that it shows some improvement in masticatory performance. So again, when you do orthodontics, you can improve the occlusal contacts, you can improve the relationship of the jaws together, but this is not a direct link to improving the masticatory efficiency of that patient or a rationale إنه أنا بدي أعمل لك هيك عشان أنت تعمل هيك. هلا أهم واحدة نحكي عنها و a lot of people they might have arguments عكس بعض. يعني there are people that claim that orthodontics will relieve TMD, and there are people that claim orthodontics will cause TMD. So إيش TMD اللي هي temporomandibular joint dysfunction. It refers to a group of interrelated conditions associated with clicking, locking, pain from the TMJ, and surrounding muscles. It is extremely common. بنحكي عن يعني معظم 3/4 population having at least one sign of these during their lifetime. Okay, and females it is more. It increases with the age, and usually it has cyclic nature يعني بتيجي وبتروح. So can we justify providing orthodontic treatment to relieve TMDs, or can we say that you have a TMD because of your orthodontic treatment that you had done before? According to evidence, there is very weak evidence. Okay, يعني they cannot relate directly malocclusions with TMDs except for very weak evidence with certain malocclusions اللي هم untreated crossbites. We will talk about them in the next lectures, that has functional shifts. Okay, but there is no evidence زي ما حكينا that orthodontic treatment causes or cures TMD. So because of this, إيش يعني الملخص? The American Association of Dental Research strongly recommends that unless there are specific and justifiable indication, okay, treatment of TMD should be based on the use of conservative and reversible treatment modalities. يعني ما بنقدر نيجي نحكي للمريض oh you have a TMD so أنا هلا I will treat you via orthodontics. You cannot guarantee that once you do the orthodontic treatment you're gonna relieve their pain, okay, or relieve their TMD signs and symptoms. What about speech? Certain malocclusions, like an anterior open bite, might actually affect speech, causing lisps in some letters. We will discuss that later with more specifications or more details. Okay. However, again, if the patient has a speech problem, it is always better to refer your patient to a speech therapist because speech is a complex process. So it's not only just about the malocclusion. If the speech therapist asks you that or determines that one of the main reasons is the malocclusion and they ask you to provide treatment, then you can do that. But however, you cannot, again, guarantee for your patients that just by treating their malocclusion, the lisp that they have or the speech deformity that they have is going to disappear. There needs to be a speech therapist involved that can train your patient to correct their speech. Trauma prevention, this is one aspect that is actually proved via evidence that showed that when the upper teeth are prominent, we have a big overjet and the teeth are coming out a lot, and there is a big horizontal gap between the top teeth and the bottom teeth. Imagine when this patient or child falls on their face. The first thing that's going to hit the ground is the front teeth. So evidence suggests that there is a high risk of trauma to the upper teeth if they are prominent. And actually, early intervention and correcting this prominency in the teeth will actually reduce the risk of trauma to the teeth. What about the psychological benefits or the self-esteem? Actually, certain malocclusions in children, like prominent teeth, large overjet, can lead to teasing, bullying, and lower self-esteem. There are also severe cases that are associated with facial disfigurements like cleft lip and palate, and these have proven to have a long-lasting psychological effects on the patients. But, however, evidence of long-term mental health improvement from orthodontic treatment is limited. يعني most of the studies show that self-esteem does change but on a short-term basis. يعني بتحسن المريض self-esteem تبعه temporarily, but on the long term they go back to their original self-esteem because they have probably other issues. So it's not just about their teeth, and just fixing their teeth is not going to fix their entire psychological or self-esteem problem. Okay? So, in a nutshell, does this mean that orthodontic treatment has no benefits? Of course not. It has a lot of benefits. We said that the most prominent one is the cosmetic one, and this is why Aslan patients come and seek the orthodontic treatment. If the patient is willing and you align their teeth and you follow up with them during treatment and you give them correct guidance on oral hygiene, they might improve their oral hygiene. They might have better access to their teeth after you close the spaces or you resolve the crowding to clean them better. However, this is not something that evidence guarantees. So you cannot promise your patient that, okay, I will provide you orthodontic treatment so that you have less caries in your mouth. No. Or I will provide you orthodontic treatment so that I can resolve your TMD problems. No. Or that I can improve your masticatory function. This is not something that you can guarantee according to evidence. You can improve it. Most of these issues are multifactorial, so if you probably improve one of these factors, there might be an improvement in these issues. But the most important thing about evidence is that you cannot promise the patient that the orthodontic treatment will resolve their issues. زي ما حكينا بالتي ام دي في mal occlusion زي cross bite with functional displacement of the mandible that are associated with some TMD. There are some traumatic bites that are associated with recession and poor periodontal deterioration of the health, and that you can actually get involved to improve that. Or increased overjets are associated with increased risks of trauma. Patients that have facial deformities can really benefit from their cosmetic enhancement by orthodontics. So it does have its benefits, but it is important for you as a professional to be very aware of what you can promise your patient and what you cannot. These are the references for the lecture that I used, the Handbook of Orthodontics and Introduction to Orthodontics. These are two books that are excellent for the undergrad level. The first chapters are the introductions, and if you read from them, that will be better and better so that you can improve your understanding of orthodontics. بدكم تعرفوا إن التقويم هو mostly about understanding. It's not about memorizing. The more you understand it, it's like a puzzle. The more it makes sense. So the more you read from a textbook and rather than just memorize slides, the more it will make sense in your brain. Best of luck. I will add my email and please let me know if you have any questions. Good luck.